Hello and welcome to the 27th Degree with Chris and Nancy. Our guest today is Dr. Saraireh, who joins us to discuss liver health. Before we begin our conversation, I'd like to thank our sponsor, Bay Coast Bank. Bay Coast Bank is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. I'd also like to give a big thanks to Ron Gamache for our intro music and the PC Institute for producing our show. And we're really excited to be in our new studio, aren't we, Nancy?
Yes, very much so. And a big thanks to Tyler Ewart.
Yes, thank you very much. So let's get right into this. Maybe you can tell us a little bit about yourself and your background, and then we'll talk a little bit about liver disease.
Sure. My name is Hamzeh Saraireh. I'm one of the new GI doctor in primary care. I joined almost a year ago. I came from Richmond, Virginia, where I did my fellowship, and for that I was in Galveston, Texas. I specialize in gastroenterology and hepatology, and I see mainly patients with liver disease in primary care. So here we are.
Excellent, excellent. So let's talk a little bit about the liver in general.
Mm-hmm.
And for our audience, just so we can take a step back and we can all be on the same page, let's talk a little bit about what the liver does and what function it has in the body.
Got it. So in simple words, a liver, it's an organ. It's a vital organ. We can't live without the liver. It's situated in the right upper part of the belly. It's almost the size of a football, if you want to say, and it's 7 pounds in weight, 7 to 10 centimeter in size in between female and male. What it does is that it does many vital functions or tasks, let's say, for the organ. Number one is storage. It stores carbs in the form of glycogen. It stores fat as well.
So it's involved with energy, basically.
Yes,
okay.
Energy based. It's also important for digestion, mainly digestion of fat, detoxification. So any toxins in the blood, it's the function of the liver to get rid of that, and storage of the mineral and vitamins. So it's multiple functions of the liver. It's important. Again, we can't live without it. So, and it's important. Yeah.
So you see a lot of liver disease, obviously.
Yes.
What are the more common liver diseases that you see in our community?
So, in the U.S. in general, as well as in our community here, it's the fatty liver disease. Fatty liver disease is the most common liver pathology or disease in the USA. After fatty liver disease, we have the alcohol-related liver disease, and then we have the hepatitis, mainly hepatitis C-related liver disease. Those almost 80% of liver disease, they're related to one of these. We have the less common diseases as well, but these are the things that I usually see in the liver clinic.
Okay. So fatty liver disease is interesting because I see a lot of it as a primary care doctor.
Yes.
And a lot of patients don't really understand that this can be a severe condition that can lead to cirrhosis and a lot of really important medical consequences. Maybe we can start talking a little bit about fatty liver disease.
Is fatty liver disease, is it just caused by lifestyle choices, or is it your genes too that will kind of?
Yes, that's a good question. So fatty liver disease, it impacts up to 30% of the U.S. population.
Wow.
So each 10 people, you have 3 of them have fatty liver disease. Most of them, they don't know that they have fatty liver disease. Fatty liver disease, usually people, they don't have any symptoms. That's why they don't know that they have fatty liver disease. If they have symptoms, usually it's fatigue, itching, loss of appetite, and then this is the early stages. The next stages that would be is that people would start having symptoms of advanced liver disease, and that time it's too late. It's too late in the track of diagnosis. Now, Is it related to genes? Is it related to lifestyle? This is a really good question with a complex answer. I would say there's many factors. There are many factors that play a role. Genes, for example, there are specific mutations in genes that would put you at a higher risk of fatty liver disease. But it's really mainly, the risk factors that we see them on daily basis. We're talking about diabetes is a major risk factor, obesity, high cholesterol, as well as hypertension. So these are really the risk factors for fatty liver disease. Now, advanced age is, with aging, advanced age is also another risk factor, as well as male gender is a risk factor.
Oh, that's interesting.
Yes.
So it's males who are more prone to a fatty liver than females?
We look at the ethnicity. Let's see who are the people who are who are more likely to have fatty liver disease. They found that Hispanics tend to have a higher risk of fatty liver disease compared to Caucasians and African Americans.
Okay.
So these are something that we can keep in mind whenever we see a patient.
So in our area, in Fall River, New Bedford, we have an exceedingly high incidence of diabetes. So I have to think that fatty liver is probably, and we have more obesity here too.
Yes.
I have to think it's higher in incidence here than in other parts of the country. Is that correct?
I didn't do any study, but I would bet.
Yeah.
If we have higher
yeah.
incidence of diabetes and hypertension and high cholesterol, then I think we would have a higher prevalence or more people who have fatty liver disease.
I'm always amazed at how many of my patients have abnormal liver function studies, which correlate ultimately when they're worked up to fatty liver. It's really remarkable.
Yes.
That's part of their annual workup with you too? Like,
Well-
is it just part of their like once a year blood work?
Well, as far as screening, you mean?
Right.
Well, actually, I'll direct that question
Yes.
to you.
So really, there's no role for screening for fatty liver disease.
Right.
Because when we talk about screening, we're talking about that. Let's say we're going to do this test. We're going to find something, and we're going to see if it's cost effective to intervene on the fatty liver disease. So if we're going to screen everyone for fatty liver disease, that's going to be a huge cost.
Right.
When you compare it, when you compare the risks and the benefits. So at this point, there's no role for screening for fatty liver disease. Now, most patients, what's going to happen is that most patients, they're going to get some type of imaging, an ultrasound, CAT scan, or they will get their annual labs. They're going to get some abnormal liver enzymes. Now, those patients are eventually going to be funneled to the liver office where they're going to be worked up for fatty liver disease and eventually intervene for fatty liver disease.
Right.
The intervention that we have fatty liver disease is really lifestyle modifications. Lose weight, control the risk factors. There is no pill that's FDA approved as of right now for fatty liver disease.
And this can be a serious condition, obviously.
Yes. So in the U.S., hepatitis C used to be the number one reason for people to have a liver transplant. In the last few years, it's been non-alcoholic fatty liver disease, which with its form non-alcoholic steatohepatitis is the most common indication for liver transplant. And if that's happening, that means that we have a lot of patients who have non-alcoholic fatty liver disease that's complicated with cirrhosis, who's going to end up being on the waiting list for a liver transplant, but they're never going to get a liver because there are no organs enough for everyone.
Right.
So it is a big problem. Yes.
So at what point is it even reversible?
So it depends on when we diagnose the patient. And this is where it comes with a primary care doctor. They found out the patient has fatty liver disease, and then they direct the patients to the right intervention and to the right specialist. So for the most part, it's reversible. Even if there is some form of fibrosis, there is some reversible. It becomes irreversible once they hit the point where there is cirrhosis.
Okay.
Once there is cirrhosis, the liver has already taken all the damage that it can get. It can't function on its own. Then this is the point where it's not reversible. So our goal always is to pick up the patients where they only have fat, some form of fibrosis, so that we can intervene and we can get them back in the right track rather than going into the cirrhosis route.
What's the definition of cirrhosis? So like what's happening in the liver? Is it like scar tissue? Is that kind of like, how would you define cirrhosis?
So in simple words, so cirrhosis is that, there's a burnout of the liver. So the liver is a resilient organ. It can take fat, it can take damage, it can regenerate. So with years of fatty liver disease, there's going to be continuous damage of the liver, and with that, there's going to be fibrosis. And once it reaches a point where there is more damage than the liver can take, this is where cirrhosis happen. And it's the last stage of liver disease. Once patients have cirrhosis, this is when patients start getting sick, and this is when the more, what would say, the risk of death increase exponentially once patient have cirrhosis.
So is there, like, when you're looking at the liver, or when you're visualizing, because most people don't look at a liver, but when you're visualizing a liver, is it just like cirrhosis starts as like a little spot and it grows to get bigger and bigger and it takes over more of the organ?
It actually starts, in different areas at the same at different times. So it's not a focus usually. Usually the whole liver would be involved.
Okay.
But it's not that, the microscopic level that the liver get impacted, and once there's more fat and there's more damage, then eventually the whole liver become cirrhotic.
So at what point am I a goner? Like if I'm like, well, if like 50% of my liver is cirrhosed, like am I still okay to go for a few more miles, or is that, like, hey,
Well, yes. So
sign up for a liver transplant?
yeah. Well, this is where it comes. The cirrhosis. If we want to speak more in detail, there is two forms of cirrhosis. There is a form of cirrhosis, but the liver still is functioning to the point that you're not getting sick. And there's cirrhosis where the liver has gave up, and now you're getting all the complications of cirrhosis. And when we talk about the complications of cirrhosis, it's bleeding, infections, start building fluids in the abdomen, in the belly, or in the legs. The eyes start getting yellow. The patient himself start getting confused. Those are the things that the liver usually takes care of.
Okay.
Once it gives up, right now it's like we're doing Band-Aid for those complications rather than fixing the whole problem.
So maybe we can talk a little bit about, since we're discussing cirrhosis and some of the manifestations of end-stage liver disease or advanced liver disease. Maybe we can talk just a bit about why those things happen with patients. Why do they have bleeding? Why do they have abdominal ascites or fluid in their abdomen?
Yes.
Just for our audience to understand.
Yes. So, one of the functions of the liver is to basically produce proteins and suction the extra water that ends up building in the abdomen. Now, when you have a liver with cirrhosis, you have a stiff liver. Now, the blood supply that's going in the liver, it's gonna go backwards, and when that happens, when the blood supply goes backwards, it's gonna go to areas that's not supposed to go, such as the feeding tube, the esophagus, and this is where patients have esophageal varices, and those can bleed, and people can die from this. Now, why do they have ascites? It's the same thing. The liver stops producing the protein, and once that happens, there is a disequilibrium in the chemistry in the abdomen, causing of shifting of fluids in the abdomen and causing the ascites.
So you have a scarred liver, basically. Blood doesn't flow through the liver as easily. There's an increased pressure now, and really even some backflow to some extent.
Yep.
And what we call portal hypertension, and that's the end result is esophageal varices or dilation of those esophageal vessels. Just like patients may get varicose veins in their legs, now they're getting them in their esophagus.
Exactly.
Or on their abdominal wall or whatnot.
Yep,
So.
exactly. So
How come those bleed out so easily? Like, what happens? Like with the esophageal varices?
Why do they bleed?
well, there's the pressure in those vessels, or their veins. The pressure in their veins becomes so high that whatever insult the patient would have would increase the pressure more, and then they'll bleed because the vein wall is really thin.
Right.
And once that happens, the risk of mortality goes up really high.
Right.
Because if the patient doesn't die from bleeding, they're gonna die from infection.
Right.
Okay.
So, my plan always, once patients start developing varices or they bleed or they have ascites, is that, the median survival for those patients is 18 months.
Oh,
So my plan is to bridge them for a liver transplant
okay.
if they're a good candidates. So once I see patients who have cirrhosis but the liver gave up, they have ascites, they have encephalopathy, which is confusion, they have bleeding esophageal varices. This is the point where I'm thinking, is he a candidate for a liver transplant or not? Because we're talking about limited amount of time that's left for the patient at that time.
What's the average amount of time that it takes for someone to get a liver transplant? Like, I know it's all about matching and everything else. And
Well, it depends, really. It depends on the cause of the reason they're on the transplant list.
Okay.
And it depends on, it's tricky because it depends also on the type of blood that you have. Is it type A, type B, type O? Some blood types, they have more livers than others. It depends, as I said, on the reason why they have cirrhosis, and on the age of the patient. Sometimes, the age of the patients, if they're more than 70-year-old, they won't be even considered
Right.
for a liver transplant. Now, we know for a fact that we have more patients on the liver transplant list than we have organs. So that's why and with the aging population, this gap is going to go up even more and more. So
do they have to get a whole liver, or can they get like a piece of a liver and like a piece will work good enough to keep
So a
your body?
piece is an option. This is usually called living donor liver transplant, where there is a family member who is okay donating part of the liver. Remember, the liver can regenerate. So let's
Right.
say someone has a cirrhosis. He has a family member who's willing to, donate part of his liver, and they match. Then what they do is that they cut portion of the donor liver, and they give it to the recipient. And if you do imaging for the donor liver a month from the day of surgery, they'll have their liver intact as if there was no surgery done.
Wow.
Because it regenerates. So that's an option, but it's tricky.
Yeah.
The living donor is more tricky because you've got different type of immunosuppression, different techniques for surgeries, and a lot of centers try to. It's more challenging because you're looking also to making sure that the donor stays healthy. You don't want to have a donor who's perfectly
Right.
healthy and then ended up something bad happening to him.
Right. Right.
So that's an option, but the other option is where they get a liver from someone who's a good candidate to be a donor.
Primacare is Southeastern New England's trusted leader in medical care. With offices in Fall River and surrounding communities, we're dedicated to your well-being. Our carefully selected team of more than 150 providers offers world-class primary and specialty medical care. Primacare doctors are supported by a skilled staff trained to deliver comprehensive radiology, imaging, and testing services. Primacare is large enough to take care of all your medical needs, but small enough to care for you personally. Primacare is by your side.
So I'm going to back up a little bit and just go back to the fatty liver. So when someone decides, okay, I'm getting scared, I'm going to change my lifestyle, I'm going to make better choices, like what makes a difference? Is it 10 pounds, 20 pounds? Like like if they're overweight?
So usually I get patients said 5 to 10% of your weight in 6 months.
Really?
That's why
And
I
that
say.
will make a little difference.
Yes, and then we go from there. I tell them, don't try to lose 20 pounds in a week. That's not going to help. That's not sustainable. I'll give them 3 months goal. I give them 6 months goal. When I see them in the office, I different patients, they have different approach. Some patients, they want to go see a nutritionist. Some patients, they want to see a weight loss clinic where they'll give them, different programs. Some patients, they want to go to see a surgeon to see if they're a candidate for bariatric surgery. So each patient is really different. But really, my goal is usually, lose weight. Let's start with 5%. It gets better, we'll go from there. And then I follow those patients every 3 to 6 months. And, what I usually try to do is that, I'm probably going to, we'll talk about that, which is, doing tests to quantify the amount of fat that you have in the liver, which we call a Fibro Scan. And by doing this, I try to do this when they come and see me, and then try to do it after they start losing weight. And we can see an objective measure that patient can see, and I can see that they are heading in the right direction.
So
Yeah.
at what point are you referring patients to Dr. Saraireh? Like, what is that criteria that you're like, all right,
Yeah.
you have to go
So
see
from a
an
primary
expert?
care perspective?
Yeah.
Okay. So I can tell you a little bit about what I do. So I have a patient who is found to have fatty liver, and that could be found in a number of ways. It could be that I did a lab test, some liver function studies that were abnormal, and I followed that up with some follow-up tests, or the patient, for some other reason, had an ultrasound or a CAT scan that showed it. Or maybe they had some right upper quadrant pain, and I did an ultrasound and it showed it. Because sometimes when the liver gets fatty, it kind of stretches against this capsule around the liver, and you get some pain in that area, correct? So these are all ways that patients can be diagnosed. And then what I do, and I think we're going to get into this, I'll often order a Fibro Scan. Taking a step back, I'll also do some workup to make sure they don't have other things going on, like viral hepatitis, other issues that can be a problem. And then I'll do a Fibro Scan, and the Fibro Scan shows us how much fibrosis there is. And that'll tell us how much scarring there is. Fibrosis basically meaning scarring in the liver. So based on that, you can get a sense of what their risk is. How much fat do they have? How stiff is the liver, meaning how much fibrosis there is, et cetera. And then, anyone who has fibrosis, they get referred.
Okay.
So
Yep.
if they don't have fibrosis, then I can follow that Fibro Scan down the road. I can put them on a diet, tell them to, work on avoiding alcohol, going on a low-fat diet, losing 10% of their body mass, which we've heard that 10% number with the
Pretty
diabetic talks
consistently,
too.
yeah.
10% is all you need to really affect a major change in your metabolism and your health. So we've heard that when Dr. Yacoub was here
Yeah.
talking about diabetes. So,
Yeah.
so that's how I approach it as a primary care doctor.
Yeah. Really, the guidelines say 7 to 10%. I start with 5. If they do 5, I'm happy, they're happy. But, that being said about, referrals from primary care, I see all type of referrals. I see patients with normal liver enzymes, but they have fat on imaging. I see referrals with patients with elevated liver enzymes with fat, and I see patients with some fibrosis as well. So what I'm trying to gauge is that different primary care doctors, they have different approaches.
Yeah.
And by the end of the day, if we can help by any point in the liver clinic, we'll be happy to participate in the plan of care of any patient.
Can a healthy, skinny person have a fatty liver?
Well, they may have a fatty liver, but it's probably not due to the same reasons someone who's obese or has diabetes or who has high cholesterol to have a fatty liver. A skinny patient can have fatty liver from alcohol.
Okay.
So fatty liver per se it's fat in the liver, but it can be due to different reasons. Number one, it's what we call non-alcoholic fatty liver disease, what we're talking about for a while. Number two is alcohol. It can cause fatty liver. Just as non-alcoholic fatty liver disease. And you have other metabolic diseases that are rare, but they can cause it, like alpha-1 antitrypsin deficiency, more, different genetic diseases that can as well cause fat in the liver. But the main 3 etiologies or factors that can cause fatty liver in the U.S. population, as I said, is non-alcoholic fatty liver disease, alcohol-related fatty liver disease, as well as hepatitis-induced fatty liver disease.
And when we talk about cirrhosis or scarring of the liver, just so the audience understands, that's the end result of a number of possible conditions.
Yes.
So it can be the end result of fatty liver, the end result of alcohol abuse, the end result of viral hepatitis, and then a number of other less prominent or less common conditions.
Yes, they all share in common the cirrhosis, which is the end-stage liver disease, but they're all different etiologies and different mechanisms that they can cause fatty liver disease.
And I think it's just important for people to understand that, because when you mention cirrhosis, automatically people think, well, I don't drink, so I can't have cirrhosis. But cirrhosis can be from a number of other conditions, such as fatty liver disease or viral hepatitis, etc.
Yes.
How much alcohol is too much alcohol?
Well, when we say, alcohol use, there is a mild, moderate, and there's severe alcohol use. And when we say severe, we're talking about 3 drinks a day for a male, 2 drinks a day for a female. When we say a drink, it's 15 grams of alcohol. So someone who may have 1 drink a day that contains 45 grams of alcohol, that's equivalent to 3 drinks. So we always have to quantify what type of drinks do they drink, but anything, to me, any daily alcohol use is too much.
Okay.
If someone telling me that they drink on the weekend, they drink on occasion, a couple of drinks, then we take that. That's socially. But severe alcohol drinking, we're talking about on average 3 drinks a day for a male, or 2 drinks a day for a female.
Okay.
I have to imagine that the U.S., just because of the obesity rate, is probably one of the countries that has more liver disease than other countries. When you just went to the Azores, what were the major things that you noticed in lifestyle that was different from America?
Well, I didn't see as much obesity, but I did definitely see some. I do think that alcohol is used as it is in the U.S. I think it's very commonly used. It's a part of
Sure.
celebration and culture, just as it is here. I don't really have a handle of how high their incidence of
Right.
alcoholism is, or fatty
No,
liver
just as a
disease.
casual visitor, I didn't know
Yeah.
if you were noticed anything that kind of struck you.
I don't know if I noticed a lot of differences, really. I mean, people were in restaurants and they were having drinks just as we do in America. So I don't know how different it really is. And I don't know their incidence of fatty liver or cirrhosis or whatnot there either.
Well, I would say that, COVID-19 has changed the whole paradigm of fatty liver disease and, the trend of fatty liver disease and cirrhosis. With the COVID-19, we've seen more drinking, we've seen more obesity. With the stay-at-home jobs, we've seen definitely more obesity compared
even
to
think
people
of that,
with who used to be more active
Sure.
before they started to work. So we're starting to see this now, a couple of years after the pandemic. So we're starting to see, more cirrhosis. We're starting to see patients who, they didn't get any care during the last 2 years for different reasons. We're starting to see all of these fatty liver, advanced fibrosis, and cirrhosis now. It's definitely uptrending compared to 5 years ago or 10 years ago.
I agree. I clearly in my practice see a lot more obesity. I see more alcohol abuse. I think COVID has had some pretty dramatic effects that really probably aren't talked about as much.
Yeah, those are the indirect effect of COVID-19, I would say.
Correct.
That has to scare you as practitioners. I mean, does that trajectory ever change? Or is it just going to go up and up and up? And, what's there to do about it?
I guess it depends where COVID goes. That'll be another podcast.
Yes,
my
but
word.
our goal always is try to put patient on the right track, make sure that they have the resources that they need so that they can go along with their life.
Okay. So we talked a lot about fatty liver. We
Yep.
talked a little bit about what can be done to treat it. Maybe we should talk about viral hepatitis or
Yeah.
alcoholic liver disease next.
Mm-hmm.
Whatever you prefer.
Well,
We'll try to get to both.
yes.
But
Let's
So-
talk about the drinkers.
okay, let's talk about alcoholic liver
Yes.
disease.
So, alcohol is very common. It's the second most common cause of liver disease in the U.S. after non-alcoholic fatty liver disease. As we said, severe alcoholism is 3 drinks for a male and 2 drinks for a female per day. Alcohol liver disease is interesting because it can come in many flavors. It can come as fatty liver disease. They come to the office in the outpatient with elevated liver enzymes, some elevation as well as fat in the liver. They can come with what we call alcoholic hepatitis, which is a life-threatening condition that we usually see those in the hospital. Patients become really sick. What happens is that people who's been drinking for a long period of time and binge drinking, and at some point the liver said, that's it, I'm done. I'm not going to take it anymore. So it just burn out for a period of time. They get in the hospital. They're yellow. They're confused. They're sick. With supportive management, we can get them in the right direction. Not all of them. There's a bunch of scores that we use, including the MADRS score for alcoholic hepatitis, that would tell us which trajectory the patient is going to go to. So some of those patients, they end up being discharged. Some of them, they start to be on medication, like a prednisone. If that works, great. If it doesn't, then they bridge to be a liver transplant candidate. And I've seen patients during the pandemic who died from the alcohol-related hepatitis. The other spectrum, which is it's going to be fibrosis and cirrhosis, and we saw those patients who become either in the outpatient with ascites or with jaundice, or we see them in the hospital with encephalopathy or bleeding. And they can come and form after they have cirrhosis with a liver cancer. So really, the alcohol liver disease is, you can see it anywhere. You can see it in the office, you can see it in the primary care office, you can see it in our office, you can see it in the hospital. And yeah, it's traumatic, I would say.
If someone's in recovery, my first question is, if you're an alcoholic, you're not getting on a liver transplant list, right?
Well, there have been change in the way transplant centers look at it. If you look at that, each transplant center, they have a different policy when it comes to liver transplant in patients with alcoholic liver disease. By the end of the day, their goal is to make this patient live. Now, they take many factors in place that would say, did the patient know that alcohol would cause bad liver? If the patient knew, did he intervene? If he knew and then he drank again, then that's different from someone who never knew. So that's how they look at it. Is the patient young? Is he not young? Does he have the support around him that's going to help him keep him away from the hospital or from alcohol? So these are the things that the medical center look at when they evaluate a patient with alcohol-related liver disease. But it's gone a long way in changing the contraindications for liver transplant. Previously, hepatitis B wasn't a candidate for any liver transplant except for hepatitis B. And now everyone can take an organ with hepatitis B as long as they take the medication after the liver transplant. Same thing with previously, we used to not transplant organs from people with hepatitis C. Now everyone is eligible to take organ that's positive with hepatitis C as long as they take the medication after the transplant. So the pool of the organs has gone up, but also the pool of the recipients has also went up because the contraindication has gone down.
Okay.
What about your lifespan, your life expectancy after a liver transplant? Like, do you add a significant amount of years?
Well, it's like a new life, I would say. It's like a new slate. So basically, the liver can work for 20, 30, 40, 50 years. That being said, the patient should follow with that transplant hepatologist and the transplant team for the immunosuppression. Make sure they don't get rejections. Make sure the liver is functioning fine. And if there are no fat in the new liver, there's no alcohol that's impacting the new liver, then the liver can last as long as the patient life.
And liver transplants, that's Boston.
Yes, in our region, that's Boston. I don't think they do in Rhode Island, and
I don't believe so.
I think they go. You have to go all the way to Connecticut or to New York.
Okay.
But Boston, you have big centers, Mass General Hospital, Beth Israel, UMass, Brigham and Women. All of these hospitals, they do liver transplant. So we have options. We have good connections.
Yeah, we live in a
those
good area.
Yeah, we have good connections. We as a GI division, we have good connections. So
Yeah.
if I need someone to be transferred over there or to be evaluated over there, then we have the right people over there that we can communicate directly by cell phone and get them hooked.
Nice.
So-
Very nice.
Excellent.
So now, do you want to go into the whole alphabet soup with hepatitis A, B, C, D?
Yeah, we can talk about that. That's all. So, hepatitis A, let's focus about hepatitis B and C.
Okay.
Hepatitis B and C, those are chronic,
Okay.
meaning that if patients get them, they can stay in them or the body can clear it.
Okay.
It's a different percentage between hepatitis B and hepatitis C. Hepatitis B is not curable.
Okay.
If patient gets chronic hepatitis B, then our goal always is to try to make the virus, to silence the virus, basically, to make the level of the virus in the blood undetectable by giving the medication. Now, if we stop the medication, then the levels go up. So there's really no treatment. We can just inhibit
Okay.
the virus. Hepatitis C, it has gone a long way over the last, I would say, 10 years. We have medications that would cure hepatitis C up to 99%. So if anyone have hepatitis C, then there is a cure for hepatitis C,
Okay.
and we have different regimen, and the state actually covers, the cost of this medication for most patients, if not all.
How do you get hepatitis?
So hepatitis, they get hepatitis B and C. They get transmitted by blood, either sharing needles, sharing razors, unsterile tattoos, IV drug use. It can be transmitted sexually, just like sexual transmitted disease.
Yeah.
Blood transfusions.
Okay.
That's rare now, but it used to be. The hepatitis B and C. This is how they get transmitted.
Okay.
Hepatitis A is transmitted with contaminated food. What we call it fake oral route. You go and you have a meal from a restaurant. Whoever is preparing the meal has hepatitis C. Then you can end up having hepatitis C, and you can transmit that to your family members.
Okay.
That's
because you're
hepatitis
living.
A. Right,
That's
right,
hepatitis
right,
A. I'm
right,
sorry,
right.
not hepatitis C.
Yeah.
Hepatitis B and C, they transmitted with blood, sharing needles, razors,
Okay.
tattoos, sexually.
Okay.
And for vaccinations, we have vaccine for hepatitis A and hepatitis B. There are 3 shots. You can take them,
Okay.
and you'll be immune for them. And hepatitis C, unfortunately, we do not still have a vaccine yet for hep C.
Although we have a cure. for
Although we
like
have a cure.
99%,
Right.
So. So should everyone get vaccines?
So for my aspect, anyone who comes to my office, I offer them the vaccine for hepatitis A and hepatitis B. And I'll hear from a lot of patients, I don't do IV drug use. I don't do any of that. For us as health professionals, every one of us is vaccinated for hepatitis B just because we're in the health system. So I would endorse vaccination for everyone, A and B.
Now, what happens if you... Never mind. I'm not going to ask that question. I answered it myself.
You answered your own question? Okay.
So, with the hepatitis, when you look at liver disease in general, is the disease process of the liver the same no matter what the cause is? Like, no matter if you have the fatty liver or the cirrhosis or the hepatitis, your liver is still going to go through those disease phases?
It's really different route for each disease. Like for hepatitis B, for example, we talked about the risk of cancer in people with cirrhosis. Now, people with hepatitis B, they are at risk of cancer even if they don't have cirrhosis, because the virus itself, it's carcinogenic, meaning it causes cancer. So those patients can end up having cancer, liver cancer, without even having cirrhosis or fibrosis. So those are a different beast that we deal with. Alcohol, fatty liver, they all have their different pathway. They all share in common the end-stage liver disease, which is advanced fibrosis and cirrhosis. That's how I would say it. Now, but all of them, by the end of the day, hepatitis C, if it stayed for years without treatment, then they're going to end up with fibrosis and cirrhosis.
Right.
Fatty liver disease, if they stayed years without treatment, they're going to end up with cirrhosis. Same thing with alcohol.
So the end result can be the same, but the pathway getting there is different.
Exactly. Now, we have patients who have both. They have risk factors for non-alcoholic fatty liver disease or metabolic associated liver disease. That's what they call it, MAFLD. They're also drinking alcohol. And those patients, they're going to get to cirrhosis earlier than patients who only drinks alcohol or only have fatty liver disease from non-alcoholic fatty liver disease. We have some patients who have hep C, alcohol, and fatty liver disease.
So what to just not have to worry about liver disease in general, what lifestyle choices should we be making? Like, what's going to promote
Good question.
like great liver health?
Well, we start with these steps. We do physical activity, try to avoid sedentary lifestyle. I would say you watch your calories. You want to meet your goal, not more, not less. You want to, if you're overweight, you start with weight loss.
Yeah.
If there's alcohol drinking, you drink in moderation, not every day. A lot of drinks. If you get checked, if you're immune to hepatitis A and B, and if you're not, then you get vaccinated. And if you have diabetes, hypertension, hyperlipidemia, then I always, for the most part, I involve the endocrine for those patients. So that we tackle from different ends. So they would help with optimizing and manage the diabetes and the hypertension and the high cholesterol. So these are really the things. But someone who's healthy, who doesn't have any problem, then just live a regular life, physical activity, count your calories, don't eat a lot, just eat what you need and you should be fine.
Now, some medication, like you hear stuff about Tylenol interactions with the liver. Can you talk just a little bit
Yes.
about that?
So Tylenol has been here forever,
Right.
since we were born. It's been there. It's used. It's the most prescribed medication. It's over the counter. You can buy it, and you can use it safely, up to 4 grams a day. So if you're taking the tablet that's 400, we're talking about 10 tabs a day that you can use safely, and the liver would be able to take take the hit from the Tylenol or
Right.
tolerate that amount of Tylenol. Now, once the patient takes more than 4 grams a day, this is the threshold where the liver start getting getting impacted. This is where the injury starts. And if patients, whether accidentally, because they're in pain and they take a
Sure.
lot of Tylenol, or it's intentional,
Yeah.
then this is going to cause a severe injury to the liver, to the point that the liver would fail and they'll go into acute liver failure, and some of those patients, they actually go into to need a liver transplant. So I always say people without cirrhosis, they can take up to 4 grams of Tylenol. People with cirrhosis, meaning that the liver is impacted and the end-stage liver disease, they can take up to 2 grams. So even
Okay.
patient with cirrhosis, they can take up to 2 grams a day of Tylenol. So Tylenol is safe. It's been there forever. We use it. We take it. I take it every day.
Right.
I mean, it's there. I think it should be fine. But taking more than 4 grams a day, which is 10 tab of the 400 or 20 of the 200, then this is the risk where this is where we take the risk that there's going to be an acute liver injury.
Older people, I always recommend to take less too.
Yes.
We use Tylenol a lot in the nursing home, for example, and we have a fairly strict cutoff of 3 grams a
Okay.
day. I don't know the science behind that, but it's been a standard for a long time. I think the problem with Tylenol that I see a lot in the community is it's in so many things, and patients often don't realize that they're getting it from multiple sources.
Yep.
So, we have them on, let's say they're on a pain medication that has Tylenol in it, acetaminophen, and then they don't really understand that, and they go out and buy some regular acetaminophen, and then maybe they're on a cold or flu medicine that has acetaminophen, and before you know it, they're at 5 grams or
Yep.
more a day.
That's true. Like, I didn't even think of that. Like, I was just taking Dayquil, a couple of weeks ago,
Right.
and that has some acetaminophen in it.
For example, Tylenol PM, right?
Yeah.
A lot of people use that to sleep. It's
Yeah.
Benadryl and Tylenol. If you don't have a painful condition, really, there's no reason to take Tylenol
Right.
PM, right? Why are
Right.
you taking the Tylenol?
Right.
Take Benadryl, which is also a very dangerous drug,
Right,
actually.
right,
We can
right.
talk about that on another podcast.
Yeah.
But, and anyone who's older, I never recommend Benadryl. They fall, they break their hip. It's a terrible thing. But anyway, yeah, it's in a lot out there. If you go to CVS or the pharmacy and you look through all the over-the-counter stuff, you're going to see it in everything.
Yep, I agree. Yep. I mean, if patient with chronic pains, they're gonna try to look for something that's gonna alleviate the pain, and whatever that is,
Right.
for the most part, their goal is to control the pain.
Right. Exactly.
So let me ask you a question. Is there anything really new and exciting coming down the pike for liver treatments or?
Well, the
Screenings.
main thing that everyone is looking at right now, all the liver community is looking at, and they're watching and they're waiting, is to find a treatment, a tablet that would help with reversing the fibrosis or minimizing the fat in patients with non-alcoholic fatty liver disease
Yeah.
or non-alcoholic steatohepatitis. There has been a lot of drugs that has been studied over the last 10 years, and they come to the FDA and they just don't meet the endpoint that they're supposed to meet. And the FDA has said, any drug that's going to help with fatty liver disease should also help lowering the risk of mortality or the death in the future. And the problem is most of those patients, they don't die from liver disease, they die from heart disease because
Right.
they have the same risk factors. So that's why there has
point.
been a
Yeah.
challenge
Right.
for those
That's a tough one.
medications and drug to get something that's too good to be true. That's
Right.
that's so we don't have an FDA approved drug for fatty liver disease yet, or non-alcoholic fatty liver disease or steatohepatitis.
Yeah.
As soon as we have one, that's gonna be a revolution in the liver world.
That would be an incredible game changer if we had a
Yes.
drug that could reverse fatty liver. And how about a drug that could reverse cirrhosis or scarring? That
Yeah.
would be
That would be a Nobel Prize.
that would be
Yeah,
amazing.
discovery. Yep.
So as we start to close our podcast, is there any message that you want to leave our audience with as far as liver health goes?
Well, I was just gonna say that the liver organ is resilient. Take care of it. Drink in moderation. If you drink alcohol, try to control your diabetes, your high cholesterol, your hypertension, high blood pressure, and try to lose weight if you're a little bit overweight, and always talk to your doctor if you have any symptoms, if you have any fatigue or pain or anything. Talk to your doctors. It can be signs of fatty liver disease, and we're always here to help, and we'll help with anything.
That's great. Well, this was really a wonderful podcast,
Yes,
wasn't it?
yes.
I mean,
Yep.
I think our audience learned a lot. I want to thank you, Dr. Saraireh, for coming and talking about liver disease. It was really, really a great discussion. Really appreciated it, and I think we all learned a lot today.
Thank you very much.
And we'll have you in again in the future.
Of course,
at some
yeah.
point.
Yep.
And I also want to thank our sponsor, Bay Coast Bank. Bay Coast Bank is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. Thank you, everyone. This is Chris and Nancy from 27 Degrees Consulting. I had trouble saying that.
Do you want me to do that part? Thank
That's
you,
okay.
everyone. This is Chris and Nancy from 27 Degrees Consulting, broadcasting from our new studio at PCI Institute.
Have a great day.